Hi, welcome this morning. Happy Veterans Day to everyone, and thank you all for being here, especially those early here on the West Coast and then those joining us virtually as well. Today we'll be discussing optimizing PARP inhibitor therapy in veterans with prostate cancer, a practical guide for VA pharmacists. My name is Brooke Looney. I'm a clinical pharmacist with the Vanderbilt Medical Center. I work specifically in the Vanderbilt Specialty Pharmacy Services, the Oncology Hematology Division.
And my name is Isabella Mazur. I am a clinical pharmacy practitioner at the Detroit VA Medical Center. I also work part-time at Henry Ford, where I primarily work with the stem cell transplant population there.
Thank you to PeerView and Zero Prostate Cancer for providing this session, AstraZeneca and Merck for providing the educational grants for this symposium. Use your mobile phone to scan the QR code on the following slides to complete the pre-event survey, answer the polling questions, and to submit your questions to the faculty and have a chance to win a prize. In-room learners get rewarded for asking the best questions. So get answers to your questions and a chance to win a $50 Amazon gift card provided by PeerView. We'll choose the best question and announce the winner at the end of the session. You must be present when the winner is announced and be a healthcare professional to be eligible. Visit us at peerview.com/prostate24 to view the slides and practice aids now and download them after the event. So we'll do our first polling question just to get us warmed up and started. So answer this question on your device, and you can select all that apply. In your practice, which of the following represents a challenge to your decision making for the treatment of patients with advanced prostate cancer? 1, staying updated on data supporting PARP inhibitor regimens in the metastatic castration-resistant prostate cancer setting, managing therapy-related AEs, overcoming barriers to genetic testing, and number 4, supporting specific needs for veterans. And you can scan that to answer the question. Our goals for today are to expand your knowledge of the evidence and rationale for PARP inhibitor approaches in treating mCRPC, equip you with approaches to counsel patients with prostate cancer about genomic testing needs, available PARP inhibitor therapies, and potential adverse events, and to offer tips for team-based strategies to optimize practical care delivery with PARP inhibitor regimens.
All right, everyone. I just wanted to echo what Brooke said. Happy Veterans Day to everyone. We definitely appreciate your time and sacrifice that you have put in. So happy Veterans Day. And then without further ado, we'll go ahead and get started with the genomic testing and PARP inhibitors in metastatic castration-resistant prostate cancer and what the VA pharmacists need to know. Briefly, just about prostate cancer. Prostate cancer represents about 15% of the new cases that will be diagnosed in 2024, which translates to about 300,000 new cases this year. The median age of diagnosis is around 67, and the 5-year overall survival, 97.5%. Majority of the patients, when they do get diagnosed, they are diagnosed with the localized stage, which has the 5-year overall survival of around 100%. Looking at the distant metastatic disease state, about 8% of those patients are diagnosed at diagnosis, and the 5-year overall survival drops significantly in this population, down to 36.6%. Now, looking at the VA population, VA serves over 9 million veterans for the healthcare needs. Prostate cancer is the most common cancer diagnosis among the US veterans, and it makes about 30% of the new cancer diagnosis at the VA. It's also important to note that where we're looking at the military personnel in comparison to the general population, the rates of prostate cancer are doubled in the military population. The burden of prostate cancer among the veterans is substantial, with over 200,000 survivors and 15,000 new diagnoses annually. Also, prostate cancer is the presumptive Agent Orange-related condition, which is important to note because majority of the veterans that we serve in the oncology section, I would say, are the Vietnam War era veterans. So this is important to recognize that risk factor for those patients. Has anyone in the group heard about Zero Prostate Cancer or used their website before? Couple of patients. So this is a patient advocacy organization that they do provide valuable resources for patients, for clinicians, and for all of us who provide care to patients. They have great patient resources that are written in patient-friendly language. They also do raise awareness around the correlation between military service and prostate cancer, and they do help to bring those resources to the patients who are actively undergoing treatment. So if you ever need patient education, try to check out their website and print some information or guide the patients to this website so they can utilize those resources. In terms of veteran population and what the pharmacist's role in delivering of the care is, I would say it's quite important that we, as pharmacists, get to know the patient and the patient's family. A lot of the times, veterans themselves end up living alone. They do have family members who come and visit them and help them with their needs, but most of them do live alone. And there's some who have families and other friends and whatnot that they live with, but majority of them live alone. And that translates into us assessing their performance status, their independence. Are they fit to be prescribed some of these different medications, and what is their goal in terms of being independent, and how do they see side effects playing a role into that. Also, it's important that we get involved beyond the cancer care. A lot of the times, as a pharmacist, we are the coordinators of care between the different teams. A lot of the times, we are helping them with the transportation needs. We are helping put in those consults, whether that be prosthetic consult or anything else that they need, nausea management. They're unable to get a hold of anybody in the VA. A lot of the times, the oncology pharmacists, because we're so easily accessible, we are the person who is there to help them navigate the VA system and help them get connected with some of these other services too. Also, it's important that we understand the journey and where they are in the treatment pathway. Usually at the beginning of their diagnosis, they are diagnosed with prostate cancer. Maybe they might not know what the statistics are. Maybe they don't know what to expect. So we should take the time to educate them about their disease state, provide that education, like what stage are they in, what does that translate into, and what to expect down the road in terms of survival and whatnot. A lot of those discussions are not always held with the provider just because they have limited time, but us as pharmacists, we do have the time to spend a little bit more time with the patient. Also, if they are diagnosed, maybe they're already going on their second, third, or fourth line of treatment, going over the data, telling them what is the expected survival, how much benefit can they get from this treatment, and how does that translate into quality of life. And maybe getting them set up with palliative medicine would be the best way to go about this as well, so they can help bridge that gap for the patient. Another important thing that we as pharmacists should be talking to veterans is counseling them about genetic testing, and then following that up with targeted treatments and opportunities to participate in clinical trials. I would say that educating the veterans on the genetic testing results, letting them know that it is highly unlikely to impact their claims for presumptive service-related conditions. I know that is quite a big concern for a lot of the veterans who are hesitant to get the genetic testing because they worry that whatever is found in those tests is going to eliminate their access to be having coverage for that presumptive condition. And then just in general, as a pharmacist, we are known as the drug gatekeepers, and we do provide holistic support to patients. A lot of the different things that we are known for are the experts in understanding the mechanisms of actions and bringing those clinical implementation approaches for different drugs such as PARP inhibitors into the practice. We are also there to support the veterans in receiving a variety of different therapies, and we are the support, and we do provide the vigilance and the educations on associated adverse side effects. We also talk to patients about clinical trials, the data from the clinical trials, and we coordinate care and provide psychosocial assessments. We help them get connected with palliative medicines, with psyching, and so many other different disciplines. So we do it all, and I always say that without the pharmacists, I don't think anything could happen in any of the medical system. Now, why are clinical trials important, and why is the participation in clinical trial important? For one, the more that we talk about clinical trials and possibility of enrolling patients into clinical trials, the higher the chances that they actually might get enrolled, which also leads to greater participation, and then that translates to having patients access to new therapies, better therapies up front versus later down the road where they might not be as fit anymore for those therapies. Also, participating in clinical trials creates that diversity that we need in clinical trials, because a lot of the times diversity is not seen in the clinical trials, and then a lot of the clinical trials are not always applicable to our patients because they did not include that population. So overall, clinical trials are the key steps for translating research into medicines that can cure illnesses, slow the disease, and improve quality of life for patients. Now, let's transition into talking about the DNA damage repair via the homologous recombinant pathway. Majority of the common causes of the DNA damage are double-stranded DNA breaks, single-stranded DNA breaks, mismatches, alkylations, deletions, introductions of different adducts into the DNA. The DNA damage response mechanisms vary depending on the type of damage. The homologous recombinant repair pathway is the primary mechanism by which cells accurately repair double-stranded DNA, and this plays into a role of PARP inhibitors' mechanism of action. These things are highly regulated by tumor suppressors, protein and complexes, which then these proteins are encoded by the genes such as BRCA1, BRCA2. On the right graph over here, I just wanted to point to everyone the incidences of different HRR genes alterations. As you can see, BRCA2 is the most common one, followed by CDK12, ATM, and BRCA1 mutations. Also, DNA damage repair is vital for maintenance of genomic integrity. Deficiencies in such HRR pathways and other DNA repair mechanisms plays an important role in development of various cancers. The HRR mutations, such as the BRCA1 and 2 losses, can lead to deficiency in DNA repair via the HRR pathway, which can lead to accumulation of DNA damage and carcinogenesis. Alterations in the DNA damage repair mechanism can also contribute to the disease progression. A lot of the HRR mutations in prostate cancers are associated with increased risk of recurrence, death, and metastatic diseases. And this is just a picture overview of the mechanism of action of PARP inhibitors. We are talking about the DNA double-stranded DNA breaks, which are encoded by the BRCA1 and BRCA2 mutations. If these are lost, the cell is unable to correctly repair, and then that leads to all that DNA damage accumulation and mutations harboring resistance to different treatments. And also talking about the BRCA1 and BRCA2 mutations, they can be somatic or they can be germline. Somatic meaning they are not found, they are not inherited and only found in the tumor, versus the germline mutation, they are inherited and found in all of the cells. 23% of the metastatic castration-resistant prostate cancers harbors the DNA repair alteration, and the frequency of the DNA repair alteration increases with the disease progression. Also, 12% of men with metastatic prostate cancer have germline DNA repair deficits, and then age and family history are not affected, do not affect the mutation frequency. So all of this translates to 1 in 10 men carries an inherited DNA repair gene mutation. So what that means is that genetic testing can be important for family members because it can help identify predispositions to other cancers and inform family members about their own risk. Now, there was an interesting poster presented at ASCO GU this year. These researchers looked at germline and somatic testing for metastatic castration-resistant prostate cancer, and what they did, they looked at the real-world data between 2020 and 2021, and what they had found is that only 59% of patients received the HRR mutation testing. And then what they found that the patients who were tested, only 31.7 tested positive for the HRR mutation, which is quite significant number, and only 68.8% of those patients who tested positive actually received a PARP inhibitor. So there is a quite unmet need in terms of making sure that we are aware what those mutations are and what are the targeted therapies available for those patients. So in summary, 40.8% of patients with metastatic prostate cancer did not receive germline or somatic HRR mutation testing, while 33.2 patients who were positive did not receive treatment. And this is where the pharmacist can play a big role in bridging that gap and making sure we bring the patients to the targeted therapy. Also, who qualifies for the germline genetic testing and somatic tumor testing? For germline genetic testing, we should be considering patients who are high risk of prostate cancer, who also have very high risk, and then have regional and metastatic prostate cancer. Just because that survival, 5-year overall survival is 36%. So those people are quite vulnerable when they are found with this type of mutation. Also, patients with Ashkenazi Jewish ancestry are at higher risk. Family history of high-risk germline mutations, people who already have the germline BRCA1 or 2 or Lynch syndrome. And then patients who have family history of cancer should get tested as well. And in terms of somatic tumor testing, it's more encompassing because it is more recommended for patients who have metastatic prostate cancer. It's also recommended that we test them for MSI and DMMR and castration-resistant cancers. So the take-home message is a lot of the guidelines of patients with metastatic prostate cancer qualify for the considerations for their germline genetic testing, and it should be offered and discussed with patients. And if they are found to have some kind of genetic mutations, they should be sent over to genetic counseling. And this chart, I know it's pretty busy, but I just wanted to point to different modalities and different groups, how you might find the germline reports, whether that be, germline testing or ctDNA reporting. For the VA in particular, those results are not integrated into the CPRS system. So where you would find these reports, it would be in the imaging section of the CPRS. And a lot of the times you will just look for the name, whether that be, Tempest, Foundation One, or whatever other test the provider had ordered. That's where it would be located. So in summary, why should we talk to veterans about importance of testing? A lot of the time, counseling patients about the reason for testing and impact of the results should play a big role in the disease management, and they should understand that we're trying to create treatment that is tailored to them, that best benefits them. And we also try to help patients understand why they might not want to proceed forward with the testing as well, and be able to proceed and help guide them through that process as well and clarify any misconceptions. Do you guys have any questions in terms of genetic testing and how you approach your patients in your clinical practices?
I think we do have a question on that.
Oh. Is genomic testing at the VA covered benefit? Yes, it is. If you follow through the pathways at the VA, it is listed as recommended, and it is something that should be utilized, because if we do test patients at that point where they do become metastatic castration-resistant cancer, then the option for those patients is olaparib, which is covered indication for those patients. So it is covered under the VA benefit. Great question.
Great, thank you. All right, we've got another question for the polling on your device. So as we move on, please take a moment to answer the following question about biomarker testing. And just a reminder to those of you in room, you can get rewarded by submitting your questions with an Amazon gift card. So I'll be talking about putting the latest evidence for PARP inhibitors into practice. And so how can VA pharmacists optimize treatment delivery? First, I'm going to present 2 patient cases that we're going to come back to as we discuss some of the clinical trials that led to development of the current PARP inhibitors. So first is Jonathan, 70-year-old male, recent diagnosis of metastatic CRPC. Testing through an FDA-approved test reveals that he has a somatic HRR gene mutation. And our second patient is Mark, 56 years old, was diagnosed in 2021 with hormone-sensitive prostate cancer and started on androgen deprivation therapy along with an ARSI at that time. ARSI is androgen receptor signaling inhibitor. His cancer has now progressed to metastatic castration-resistant prostate cancer, and the FDA-approved test reveals a BRCA mutation. So first, we're going to look at our 2 PARP inhibitors that are approved for monotherapy in metastatic CRPC. First is olaparib. FDA approval was based on data from the PROfound study for the treatment of patients with a pathogenic germline or somatic HRR gene mutated metastatic CRPC who have progressed following one prior treatment with enzalutamide or abiraterone. For rucaparib, our second approved in monotherapy space, FDA approval is based on the Triton 2 study for the treatment of patients with a deleterious BRCA1, to germline or somatic mutation, and they had been previously treated with an androgen receptor-directed therapy and a taxane-based chemotherapy. So it's important, as we are going to go discuss some of the clinical trials that led to approval, is to look at the germline or somatic mutations and also the prior therapy that the patients might have been on previously. So first, we're going to discuss olaparib with the phase 3 PROfound trial. Note the difference on the left side is the curve showing the radiographic progression-free survival. Patients were previously treated with docetaxel plus an ARSI. This was a biomarker-guided trial, so there was 2 cohorts. Cohort A, patients were BRCA 1 or 2 positive, also included patients with an ATM mutation. Cohort B were the other HRR mutations that Isabella discussed in her section. Olaparib versus the control. The control was enzalutamide or abiraterone, the physician's choice on that. This study showed a significantly statistic longer time to radiographic progression-free survival with a 66% reduction in risk for disease progression or death. Our second curve shows overall survival, which was statistically significant. You can see here median of 19.1 months for patients in the olaparib arm versus the control arm of 14.7 months. Olaparib was also associated with a reduced pain burden and better preserved health quality of life compared with the control. So our second trial that we're going to look at in monotherapy was the rucaparib in the phase 2 Triton trial. Patients in phase 2 had received 1 or 2 prior lines of therapy. They also had BRCA 1 or 2 mutation. This trial showed that there was a median radiographic progression-free survival of 9 months, which really reinforces that PARP inhibitors are important in the treatment of the BRCA-positive mutations and really solidified its place in treatment there. Phase 3, the Triton 3 trial, was patients that had a BRCA 1 or 2 mutation, but also included patients with an ATM mutation. It was rucaparib versus the control, which was docetaxel or an ARSI. This trial met the primary endpoint of radiographic progression-free survival. So the rucaparib arm, 11.2 months, and then the control arm of 6.4 months. Note that rucaparib did not show benefit in the ATM subgroup, so just the BRCA 1 and 2 subgroups. So now we're going to move on to our FDA-approved PARP inhibitors in combination for metastatic CRPC. So the biologic rationale behind combining 2 forms of treatment, so the PARP inhibitor plus an ARSI combination, is that there's a synergistic mechanism of action for PARP inhibitors and the ARSIs. PARP inhibitors upregulate androgen receptor signaling, which enhance the ARSI activity. And conversely, the ARSIs inhibit the transcription of some of the HRR genes, inducing an HRR deficiency-like state, which potentiates the PARP inhibitor activity. So they're both working in tandem together. We have 3 regimens that are approved for first-line treatment. The first is olaparib plus abiraterone, which we'll go through the results of the PROPEL trial. The second combination is niraparib plus abiraterone, and then the third combination is talazoparib plus enzalutamide. So first we're going to go through the first-line approval for olaparib plus abiraterone in the phase 3 PROPEL trial. So you can see for our curve on the left there, the radiographic progression-free survival was statistically significant in all comers and the intent-to-treat population. Consistent with radiographic progression-free survival, overall survival on the right curve there was also observed. Olaparib plus the PARP inhibitor prolonged overall survival in this group by 7.7 months versus the standard of care, which would be abiraterone plus placebo. Next, we're going to discuss the phase 3 magnitude trial, which was niraparib plus abiraterone. We saw radiographic progression-free survival significance in the BRCA subgroup. The control group was placebo plus abiraterone. Abiraterone is given in combination with prednisone, so that's that AP designation there, versus the placebo group, which was just standard of care, like I said, abiraterone plus the prednisone. There was a significant improvement of progression-free survival with the BRCA arm being 19.5 months versus 10.9 months in the control group. Of note, the HRR subgroup, so the non-BRCA mutations, did not show significant benefit. Which this really emphasizes the importance of identifying the molecular subset of your patient. And then finally, we'll look at phase 3, the TALAPRO-2 trial. TALAPRO-2 included talazoparib plus enzalutamide versus a placebo plus enzalutamide as the control. The combination resulted in a 37% reduction of risk for progression. Also, there was a clinically meaningful reduction in risk of progression or death observed regardless of the HRR subgroup. So anyone that was HRR mutation positive received benefit in this trial or showed benefit. And those trials will become important when we're talking about selection of therapy for the patient. So moving on to common side effects of or adverse events with PARP inhibitors, where pharmacists really can help the providers in monitoring patients for these side effects and help mitigate with mitigating strategies as well. So first, because of the PARP inhibitors being used in combination with the ARSIs, we're going to see more hematologic side effects with the combination. So anemia, thrombocytopenia, neutropenia can be common, and that really is attributed to that addition of the PARP inhibitor. The non-hematologic side effects are mostly GI, so nausea, vomiting, diarrhea, or constipation, and then asthenia and fatigue. Rarely, there are risks for AML, MDS, and pneumonitis. So first, we're going to discuss the hematologic adverse events and how we can manage those. So we would interrupt the PARP inhibitor and monitor blood counts weekly until the AE resolves to grade 1, or until it reduces to grade 1 or resolves. If the hematologic profile recovers, consider restarting the drug at a reduced dose, and we'll go through those dose reduction regimens in some following slides. Patients will need to be monitored for the first month weekly, CBC. Months 2 to 12, you want to make sure the patient's being brought in monthly for monitoring. I know that in practice, we typically will kind of align that with when the refill is due for their next month cycle. And then after month 12, the patient is stable, then you're going to monitor a patient periodically. If the hematological profile has not recovered to grade less than 1 after 4 weeks, less than or equal to 1, then you would want to refer that patient over to hematology for bone marrow analysis and cytogenics. For our non-hematologic adverse events, it's important to send patients home with an antiemetic or make sure that they've got that on hand. So prophylactic antiemetics about 30 minutes prior to the dosing, potentially PPIs for patients with dyspepsia or start to experience dyspepsia. And then if the antiemetic they have on hand is not working, definitely reevaluate and change to a different one with a different mechanism of action. So typically we're starting with those 5-HT3 antagonists in practice, but if those are not working, then you can look at the dopamine agonist as a possibility, or lorazepam. Some complementary supplements. I know we have some patients that don't want to add on additional Tablets or their pill burden is potentially ginger, CBD oil, or acupuncture. And then also lifestyle modifications can help with those GI side effects. So the PARP inhibitors can be taken with or without food, but some patients do tolerate better if they take their medication with food. Also, eating smaller, more frequent meals throughout the day versus large meals can help with that as well. And then for nausea, taking it at bedtime can help patients if they're having a lot of nausea throughout the day. Potentially they can sleep through some of that nausea. Conversely, if patients are having trouble with insomnia and if nausea is not a concern, then taking in the morning can help with that insomnia. And then when we're looking at fatigue, you're going to ask the patient to really monitor themselves weekly and report that weekly and monthly. You want to educate the patients that fatigue level is very common with PARP inhibitors, and then it does tend to improve. So what we see in practice is usually 2 to 3 months. That first 2 to 3 months can be rough as far as the fatigue. So it's important to be checking in with the patient and asking them to rate their fatigue and their level of function. Some questions you can use to ask the patients would be, what are you unable to do this week or month that you were able to do prior to starting PARP inhibitor therapy or prior to starting this regimen? And then also important would be to involve the caregiver for their observations. Sometimes patients are not as forthcoming, and not necessarily intentionally, but caregivers can often give you a different perspective. So it's important to include those caregivers in the conversation. And then also you want to rule out other causes, so anemia, insomnia, depression, low thyroid. If the other medical etiologies are ruled out and it seems like it's just the drug-related fatigue, then you would want to encourage exercise, just getting up and moving around, whether it be going to walk around the block, down to the end of the driveway and back. Just keeping active can help reduce that fatigue factor. And then if those modifying strategies really are not providing the patient any relief, you can consider a dose interruption or a dose reduction for severe fatigue. When looking at monitoring and managing hypertension and cardiovascular AEs, you want to monitor blood pressure and heart rate weekly again for the first 1 to 2 months, and then monthly through months 3 through 12, and then periodically after a year on therapy. Closely monitor patients with cardiovascular disorders, which I know a lot of our patients will fall into that category, and make sure that their hypertension is being managed with antihypertensive medications and dose adjustments if necessary. I know that in our academic medical practice, if we do have patients on treatment that are having a hard time managing hypertension or we're concerned about cardiovascular risk, we do try to include the cardiology team at Vanderbilt. So practical considerations for pharmacists. So what we're going to do is kind of review all that we've discussed. So the indication for the monotherapy, so olaparib, we're going to start with those first two. So olaparib has approval for progressive metastatic CRPC, BRCA mutated or HRRG mutated as monotherapy. So that would be in your patient population that's been previously treated. For first-line treatment, there's approval for metastatic CRPC, BRCA mutated in combination with abiraterone plus prednisone. You can see the starting dose there. Also, we included the tablet formulations so that you're aware of what strengths the tablets come in. That can be useful when counseling patients to make sure that they understand, for example, that they'll be taking 2 tablets twice a day. And then we discussed previously dose reductions based on the side effects. So we've got the first dose reduction listed there, 250 milligrams twice a daily for olaparib. And the second dose reduction would be the 200 milligrams twice daily. Note that would require a change in tablet strength from the 150 milligrams to the 100 milligram tablets. And then if the creatinine clearance is 31 to 50, we're going to reduce that starting dose to 200 milligrams BID. For rucaparib, the indication is for monotherapy progressive metastatic CRPC with a BRCA mutation, 600 milligrams twice a day with or without food. And then we discussed if the patient is having trouble with nausea or GI upset, then they would benefit for taking that with food potentially. And then we've got the dose adjustments listed there as well. So when we're looking at our combination therapies, niraparib is indicated for BRCA-mutated mCRPC in combination with abiraterone and prednisone. We can see, again, our starting dose and then our tablet strengths and sizes, and then the dose adjustment. Note the dose adjustments for hepatotoxicity in this combination of abiraterone with niraparib, and then also our hematologic dose reductions as well. And then talazoparib approved for metastatic CRPC, the HRR gene mutation, so not specific to BRCA, in combination with enzalutamide. And we've got our dosing plus our dose adjustments there as well. So just to review our adverse events, we talked about the GI side effects, the hematological side effects. When we're looking at the grading on those, this can be a good guide for when to hold medication based on the grade of side effects. If you'll remember, when we hold and we are thinking about resuming the patient, then you would want to wait until that side effect has been reduced down to grade 1 or less, and then potentially resume at a reduced dose or that reduced dosing schedule that we looked at earlier. So we're going to update on our patient cases. First, we're going to discuss, again, Jonathan, who was our patient with a diagnosis of metastatic CRPC and has a somatic HRR gene mutation. So options for initial therapy for this patient with a recent diagnosis would be any of the combination treatments that we discussed.
And then, Brooke, question for you. A lot of the patients, let's, for example, have uncontrolled diabetes. How would that alter your treatment pathway?
Yeah. So if your patient had uncontrolled diabetes, when we're looking at our 3 regimens for combination therapy, if uncontrolled, you would probably most likely want to avoid the combinations that had prednisone and steer more towards the combination without the prednisone component for those patients. Another important thing would be to make sure that you're reviewing with your patient, like I talked about, the dosing regimens. Calendars and electronic tools can be very helpful to convey those dosing schedules, combined with calls from the pharmacist. So when we have an outreach program where we reach out to the patient 7 days after starting their PARP inhibitor combination therapy to check in and see how they're doing with the GI side effects. And then we're following those patients weekly for about the first 60 to 90 days just to check in on them to see how they're doing with the fatigue factors as well. So our second case, if you'll remember, was Mark. Mark had a previous history of metastatic hormone-sensitive prostate cancer, and he had been started on androgen deprivation therapy along with an ARSI, so that would be abiraterone, enzalutamide, darolutamide. The cancer has now progressed to a metastatic CRPC, and if you'll remember, the FDA-approved test revealed a patient had a BRCA mutation. So the next course of therapy would be a monotherapy with our PARP inhibitor. So rucaparib or olaparib would be an option for this patient.
And Brooke, we have an audience question as well.
Oh, sure. So for the olaparib trial, what did they use to define an increase in quality of life for the patients? So they did use a quality of life questionnaire. There are several out there that they're using in clinical trials. Those tend to be pretty lengthy, so 25 to 30 questions. I'm not sure exactly which survey they used for that trial. That's definitely something I can get back to you with. But they did use a standardized. I know that in practice, Isabel and I had this discussion about, how do we do that in practice, monitoring patients' quality of life without asking them a 25 to 30 questions on a questionnaire. And really, we have found in our practice that reaching out to those patients continuously, weekly, for that first, I said, like 60 to 90 days has been really helpful with building a relationship with the patient so they're feeling comfortable with reporting how they're feeling. We have the same pharmacist reached out to those patients So they, like I said, become very comfortable and really open up to let us know how they're feeling. Another important thing would be to, like Isabel discussed in her portion, would be to involve the caregivers in that process.
And we do have another audience questions. What do you find works best to describe or explain expected adverse events from PARP inhibitors to patients? What to relay, pay attention to, and what will subside? So for me, a lot of the times, like when I do provide the education about PARP inhibitors or whether any other drug, I tend to print a patient handout from the HOPA ONS website. They do have greatly laid out side effect profile. They focus in on the most common side effects. And on the other side of the page, it's like a table. They go through some of the ways that you can manage at home before you even get to your provider. So some of the tips and tricks on how to focus in on that. And those are great, especially like if your sites don't have anything that's already prepared to, already handmade or anything like that. So these are already pre-made, vetted by oncology pharmacists, vetted by the oncology nurses, and they go through the packaging, so they focus in on the most updated and most common side effects for that too.
Yeah, I would agree. Those resources are great. I know in addition, we have a kind of a flip chart that we've developed through our education team at our academic medical center that we hand out to patients that really kind of stepwise go through how to manage those side effects at home. So making sure they have the antiemetic on hand. Also, fatigue can really be a big factor with these combination therapies and monotherapy. And so we found just, reminding the patient that this, like the fatigue is normal, and just, checking in on them and letting them know that, the fatigue should improve and subside over the next couple of months. But then also, reminding them that there are things we can do if the mitigation strategies that we've talked about at home aren't working. We can always hold the dose and see how that goes. Also, reduce the dose as well.
And like Brooke said, a lot of the times I will send patients either the antiemetics or antidiarrheal at home, but I also try to be cognizant about like refills and whatnot. A lot of veterans are preoccupied with how many medicines they receive at home and how many copays they pay. So I usually will give them 15 days supply with one refill just in case they are having issues. Beyond that, if I do notice that they're having issues, we will bring them in, try to have a reevaluation, see what's going on, whether we need to check an EKG, whether we need to change medicines to a different one. That's like where we're going to be checking in with them to make sure we optimize that care for them too.
Yeah, I think the key point is just to tell patients up front there are things we can do to help mitigate and manage these side effects. So as we move on, please take a moment to answer some of the follow-up questions about management approaches for PARP inhibitor therapies. So you can answer that on your device. So kind of to emphasize what we were speaking about earlier as education with the patient, you really want to communicate the big picture of the treatment plan early on, remind the patient of the next steps as they approach. You want to share timely and up-to-date information with patient and caregivers. So talking about there's different options. There's different PARP inhibitor therapies that are and options that have different side effect profiles. Also talking about the mechanism of action. So why are we using multiple drugs in combination to treat possible side effects before initiating therapy, and then throughout the treatment, and also survivorship. So long-term goals for the patient.
It's also important to communicate that even though this is not chemotherapy, IV chemotherapy, there are different unique side effects to these different medications. They are taking this at home, so they do need to take precautions, whether, how are they stored? Are they making sure they're keeping away from kids and pets? And, if they do have a partner, that they are using some kind of, barrier methods for sexual activity and stuff like that. So these are the things that we should be talking to them about. Also, we should be encouraging patients to call us as soon as they're having any kind of issues and not to wait until their next doctor's appointment, which could be, 3 months down the road or anything like that. I usually would give the patients my direct phone number so they can call me if they have any issues. I know a lot of veterans can be frustrated with getting a hold of somebody at the VA because they get transferred, 5 to 6 different times before they reach the appropriate person. So having that point of contact and a direct line to you also helps save a lot of time for them and the frustration that they might be experiencing. And also, equip them with those handouts, give them the education that they need to manage it at home. And then if they are having greater issues, call us and let us know that we're here for any and all help that they need.
So pharmacist's role in the patient engagement. So as we've discussed earlier, act as the patient advocate. So provide patient-friendly information about therapy options, whether it be ASRI, PARP inhibitors, combination, and what to expect. Also, you want to educate the patient up front about adverse events and management strategies. Explore social systems and social factors through various methods. So that can include transportation to clinic, getting the patient connected with support groups like Zero, also with social workers or caseworkers as well. And those can be verbal communication, written communication, communication with care partners, also phone recordings or reminders about refilling medications, and then calendars to keep up with dosing and with appointments. And then also to continue to collaborate with other HCPs to ensure that continuity of care. We mentioned patients, in this age group do have cardiovascular issues, also diabetes can be common in this group of patients as well. So making sure that we're helping to manage that whole picture. So just to review some resources to provide with your patients, and we talked about Zero, which is the national leader in prostate cancer advocacy. Zero provides millions of patients and their families with disease information. So there's websites, there are printed materials, there's videos. So I encourage you to check that out, www.zerocancer.org. And then reputable information can also be found helping patients to navigate issues surrounding their impact of therapies on their day-to-day life. So looking at their quality of life is important to consider. And then empowering patients to kind of share in that decision making. So presenting them with the evidence and that there are choices in therapy. And providers can direct their patients, once again, to these groups. We talked about Zero, but also the Prostate Conditions Education Council, American Cancer Society, the Prostate Cancer Foundation, and then the NCCN guidelines for patients are all really good references and resources for patients.
And we do have a question from the audience as well. Do DoD or TRICARE beneficiaries have access to the same genetic testing, or can they be referred to the VA facilities in order to receive this care? VA DoD resources sharing agreement. I'm not entirely sure about the DoD TRICARE. I do believe that they do fall under the same pathways as the VA treatment medical pathways. And if it is not covered in the community care setting where they are following, they can always be referred back to the VA, and the VA then will pick up through the community consult care, or if they want to get established at the VA, they can, and then that's where it will kick in under the VA care.
And I'll go ahead and take the next question that came through. So at the metastatic CRPC stage at VUMC, who is taking over the patient care, the medical oncologist or the urologist? That's a great question. So the urology team is typically referring those patients at the metastatic CRPC stage over to the medical oncologist. However, we do have a day that in the urology clinic where they are specifically seeing patients with metastatic castrate-resistant prostate cancer. So sometimes they're seeing both urology and medical oncology, but typically those patients are referred over to the medical oncologist at some point once that MCRPC stage is reached.
And at my particular VA, it seems that the oncologists are resuming the care at that point in time.
So in summary, PARP inhibitors have transformed clinical care for patients with metastatic CRPC. As we discussed, biomarker testing is imperative for your patients. So all patients with MCRPC who have BRCA1 or 2 alterations should receive a PARP inhibitor monotherapy if they've experienced disease progression on previous ARSI, or PARP inhibitor therapy in combination with an ARSI if they are diagnosed MCRPC as a first-line treatment. Be aware that different issues may arise with PARP inhibitors and various combinations. There's distinct AE profiles with the PARP inhibitors and with the ARSIs, and so dose adjustments may be needed. You want to provide patients and their family with tips for incorporating into their daily routine. And then prioritize clinical trial involvement for all patients with a focus on increasing diversity. It's really important for us to educate the patients on clinical trials and encourage their enrollment. And then also educate patients and care partners. Oftentimes they will ask you questions that they won't ask the doctors. Isabel mentioned we also, our clinical team, our pharmacists give our patients our direct numbers as well. And so often when they can't get in touch with their provider, then they will get in touch with the pharmacist. Also, they also may feel more comfortable or feel like the pharmacist has more time to go through those questions versus kind of that rushed provider visit. So be prepared, so know what side effects are out there, what to what to predict, and then also know how to answer those questions and know where to direct those inquiries that you might not have an answer for as well.
And Brooke, we have a couple other questions in the audience. First one is, how is therapy modified in patients with end-stage kidney disease or dialysis?
So depending on the agent, several of the agents do not require dose adjustment. So that would be definitely specific to the PARP inhibitor or ASRI that you're looking at. So that would be an important consideration.
And then the other questions from the audience is, what causes PARP inhibitors to stop working? And what, if and any, next steps can be taken when they do stop working? I mentioned in my section too that a lot of the times it is accumulation effect of like the different mutations. Some patients, as they go down the road, we are targeting, like for example, BRCA mutation, but there might be low percentage of this other mutation. So when we're finally targeting that one pathway, the other pathway might start to take over as well. So the cancer is evading the mechanism that that we were targeting to try to evade, and then different therapies are available as well afterwards. Like we would follow either chemotherapy, which are more intense too.
Yeah, I was going to say, so we're looking at, what were they previously treated with can definitely be considered when thinking about other treatment options, but chemotherapy would be an option as well.
And we have one more question. It says, chemotherapy is always intensively monitored by licensed provider or pharmacist, which is expensive for patient and their insurance. Do you have any course of action or thinking about putting in place strategies that will lead to safely outpatient treatment instead of inpatient treatment?
So at our academic medical center, all of our chemotherapy is given in an outpatient setting. So we do have strategies to monitor those patients if they're receiving chemotherapy versus oral treatment at home. They're definitely seen more frequently. Obviously, they have to come in for IV chemo versus oral, so we're able to check labs at that time and check in with the patient.
And then one more question came in. In your opinion, is DoD prostatic cancer skewed with rough 80% of members being males and 16% of being African Americans? I do think that there is definitely that component. As the military, evolves and years go on, there's more female veterans present as well. So that data, might not change as much because females don't get prostate cancer, but a lot of the service members are African Americans, depending like which division that you're looking at, which could African American men do have a high risk of developing prostate cancer, so that could be contributing to the different numbers and higher risks of military exposures. But a lot of the times, the veterans who did go to the Vietnam or who are exposed in the burn pits area, these are some of the carcinogens that can cause prostate cancer as well. So not sure that race necessarily plays a role in skewing those numbers, but it definitely can impact it a little bit too.
So I'll take the next question. So what other colleagues from other disciplines do you communicate with for the most patients on these regimens? So I mentioned cardiology is probably the most common who we communicate with, and then also bringing in endocrinology if patients are having trouble with management of diabetes.
And I will also refer patients to palliative care, especially when they do end up having metastatic disease, that whether to the bone and they have pain and some of these other psychosocial issues as well, and maybe they're not dealing with, the diagnosis too well. So I will refer to psychon and palliative medicine too, quite a lot.
And the next question, can patients monitor their blood pressure at home while on these regimens, or should they come in each time? Now, they can definitely monitor their blood pressure at home, encourage patients to keep a log. I know that we have a method for patients to message our providers through our electronic portal. So that's been helpful, where they can send their blood pressure readings for the past week through the electronic portal, and we can review those. If we feel like the patients are being poorly controlled at home, then definitely bring the patient in to adjust their antihypertensive medications. And then making sure, I think it's important to make sure the patients have a good blood pressure cuff at home, that it's not a wrist cuff, and that they know how to work it, and that they're using it properly as well.
And then one more question came in. What are differences between VA versus academic versus community pharmacy practices? I guess I would say, like, working or having experience in both the private sector and the VA, I would say that at the VA, you don't necessarily have to battle the insurance to get these agents covered, because there is a pathway where you can follow, and if they do have the mutations, they are qualified for the drug and we are able to prescribe it. So I think that's the big difference, where we don't have to fight the insurance to get these agents approved, versus, in the private sector, they might prefer one versus the other. So you have to play that game as well.
We don't have a formulary for our oral oncology medications, so it's really provider choice. You're not really directed if there's several different options. I think that can be a benefit if a patient's having, a lot of hematologic side effects on one PARP inhibitor, and you want to change to another PARP inhibitor if you can't get those hematologic side effects under control. So that's always an option. And then additionally, as Isabel mentioned, there is that kind of more of a financial component that we see in the community practice or at the academic medical centers. We have a team that really specifically works through insurance approvals, and then also affordability. So even our patients that are on Medicare are seeing really high copays with these combination regimens. Of course, that will change a little bit in the coming years with the Inflation Reduction Act, but we're seeing out-of-pocket costs in the several thousands. So looking at, there's a lot of different resources out there for assistance for patients through different nonprofit organizations, different foundations. Also looking to manufacture programs for assistance as well for patients that are, uninsured. We do see a handful of uninsured patients in our setting, and underinsured patients. So that's an important factor that comes into play in that community and academic setting. So having a team in place to know that those are going to be issues and to help address those up front has been helpful.
And then we do have another question. Do you recommend info cards or some easier approach to send home with patients to help them manage, especially when the dose adjustment may be needed? I would say yes. Like I said, I primarily use a lot of the HOPA ONS patient education materials, where they do talk about the different side effects, and in every single section it says if these side effects are uncontrollable, call your provider, discuss the next steps, and then that is when we can talk about the dose reductions as well. And I always tell patients up front, if you are not tolerating this medicine, let us know. There are different dose reductions that we can do to help you manage these side effects to get you through the treatments. You do not have to be on the full dose to receive the effect, because even at dose reductions there is benefit to these medicines. So let us know up front from the very beginning.
And then next question, what is your best advice for helping a patient manage GI issues while on PARP inhibitors? So my best advice would be to make sure that the patient is going home with an antiemetic, so they have one on board in case needed, and that they're not scrambling at night to get a prescription. And then also making sure the patient knows that if, first of all, that they need to repeat the dose of the antiemetic if it's not working. I know I've talked with patients and they're like, yeah, I took one tablet of the ondansetron and it just did not work. So, encourage, if they're having continued nausea, encourage scheduled dosing of their antiemetic, and then taking the antiemetic about at least 30 minutes before the PARP inhibitor. And then we mentioned too, taking PARP inhibitors with food can help as well. And then other gastrointestinal issues, if they're having dyspepsia, discuss PPIs as well.
And then I will also say, make sure that they do actually pick up the supportive medicine. A lot of the times we do prescribe some of these different things and the patient goes home and they actually forgot to stop at the pharmacy to pick up their medicine. So please ensure that they actually pick up the medicine so they have it at home.
Those were some great questions. Thank you so much to
much.
everyone in the audience for sending those.
And I guess now we will.
Oh, yes, and now there will be a winner for the $50 gift card. Oh, it's on the tablet. Okay.
Oh, I don't see it.
Oh, there's 3 winners. Okay. So we have Carolyn, Preston, and Hope. So congratulations.
Would you, for the winners, can you please stand up so that we can distribute the cards?
Congratulations.
Congratulations. And thank you all so much for listening to us at this very early morning. So
Yeah. And just a reminder to visit us at peerview.com /prostate24 to complete and submit your post-test and evaluation to get your credit. You can also download the slides and the practice aids, and then you can watch a replay of this event in the next 24 hours and online activity in the next few weeks. So thanks for joining us, everyone.
yeah, thank you.